Okay, let's shift gears a bit. We've spent a lot of time on photons, haven't we? Thinking about IMRT, VMAT, SRS, SBRT, all these tools we rely on for those deep, complex targets.
Right, the real workhorses for many sites.
Exactly. But sometimes, the target isn't deep. Sometimes it's right near the surface. And for those kinds of battles, we need a totally different kind of weapon. We need electrons.
Absolutely. Electrons really are the clinical mainstay for treating superficial volumes in radiation oncology.
Yep.
And understanding their unique physics isn't just like abstract theory. It directly impacts how well we can treat things like skin cancers or post-mastectomy chest walls or boost nodal basins. And this is key, while critically sparing those deeper, often vital structures right underneath, it's just a completely different approach compared to photons.
And that difference, it starts right at the fundamental level, doesn't it? It's not just about how deep they go.
No.
It's how they interact that's different. So today, let's really let's dig into what makes electrons behave the way they do. We'll look at how we actually get an electron beam from a LINAC.
Okay.
Explore those very distinct depth dose curves, see how the beam shape changes as it goes through tissue, tackle some really crucial planning points.
Yeah, the practical stuff.
And then wrap it all up by looking at their main clinical uses.
Sounds like a good plan. Let's start right at the beginning then, how we actually make these beams and, their basic nature.
Okay, let's unpack that. So electrons, fundamentally, they're light particles, negatively charged.
Right.
And that charge is key because it means they interact electromagnetically really readily with the atoms they bump into.
Mm-hmm.
Unlike photons, which are neutral and ionize indirectly by, kicking out electrons.
Secondary electrons.
Electrons themselves are directly ionizing. They deposit their energy by knocking other electrons out of orbit or just causing atoms to get excited.
And that direct, very frequent interaction is what gives them their defining characteristic, that definite finite range in tissue.
Right.
Photons, being neutral, they can penetrate much deeper, right? Their intensity drops off exponentially, but theoretically, you never quite get to zero dose way out there. Electrons, though, because they're constantly losing energy through all these collisions and interactions, they slow down and eventually just stop completely within a fairly predictable depth.
Which clinically is just incredibly useful, isn't it?
Oh, absolutely.
Like imagine treating a skin cancer right on the chest wall. If you used photons, even with perfect shaping, you'd still have dose going all the way through the lung, maybe hitting the heart, the spinal cord.
Right. Unwanted dose deep down.
But with electrons, because they stop, we can cover that shallow target and feel pretty confident that the dose just plummets right below it. We're effectively sparing those deeper organs.
Exactly. That's the whole point. So, okay, how do we actually produce these electron beams in our standard linear accelerators? We start the same way as for photons, really.
Right, accelerating electrons to really high energies down the waveguide.
Down the waveguide. But here's where it gets really different from photon mode. A fundamental switch.
Okay.
To get an electron beam for treatment, those high-energy electrons coming down the waveguide, they are not aimed at the heavy metal X-ray target.
Ah, right. That target gets moved completely out of the way.
Correct. That target is what the electrons hit in photon mode to produce the Bremsstrahlung X-rays, the photon beam. For electrons, target out.
And something else gets moved out too, right? The flattening filter.
Critically, yes. The flattening filter is also retracted or moved out of the beam path. That filter, it's that cone-shaped absorber designed specifically to make the photon beam intensity uniform across the field.
Because photon beams are naturally peaked in the center.
Exactly. But since we're dealing with electrons now, and their scattering properties are totally different, we don't need that filter. In fact, we don't want it in the way.
So you got the target out, the filter out.
Mm-hmm.
What you're left with is this really narrow, intense pencil beam of electrons coming right out of the waveguide window.
Mm-hmm. A very narrow beam, not clinically useful like that.
No, you need to spread it out.
That's where the scattering foils come in. So located after the waveguide window, but before the beam gets further down towards the patient, there are these thin sheets of material.
Okay.
Usually a high Z material like lead, or sometimes they use dual foils, maybe different materials to optimize the spread.
And the pencil beam just goes right through them.
Right through them. As the electrons pass through these foils, they undergo lots and lots of small scattering events, interacting with the nuclei of the foil atoms.
Coulomb scattering.
Multiple Coulomb scattering, yeah. And this process basically spreads the beam out laterally, turning that narrow pencil into a much wider, more uniform distribution that's actually suitable for treating patients.
Okay, so the foils take the narrow beam, spread it wide. What happens next? Collimation.
Yes. So first it passes through the primary collimator, which is fixed, and then it goes into what we call the electron applicator or cone.
Right, those bulky things we attach to the head.
Exactly. They're physical structures that attach right onto the linac head and usually extend down quite close to the patient's surface. They do a couple of things. Define the initial field size, and they also provide some scattering material close to the patient, which can influence the dose distribution.
And then for the really precise shaping, to match the tumor volume exactly.
That's where the custom cutouts come in.
Cerebin, usually.
Typically made from a low melting point alloy like cerebin, yeah. Or sometimes lead, maybe even MLCs on some specialized systems. But usually cerebin cutouts, they're placed right at the very end of the electron cone, just before the beam exits towards the patient.
And they define the final treatment shape on the skin. So that's the whole chain. Accelerate electrons, move target and filter, spread with foils, then shape at the cone, and the final cutout.
That's the production line.
Okay, so now we've got our clinical electron beam. Let's talk about what happens when it actually hits the patient's tissue specifically, the depth dose characteristics. This is like the fingerprint of an electron beam, isn't it? And totally different from photons.
Oh, completely different. If you plot a percent depth dose curve, a PDD for electrons, and compare it to a megavoltage photon PDD, the shapes are fundamentally distinct. They just scream different physics.
And the first thing that jumps out, especially if you're used to MB photon skin sparing, is that really high surface dose with electrons.
Absolutely. That's a critical difference. Electrons do not give you that significant skin-sparing effect you see with megavoltage photons. The dose right at the patient's surface is usually quite high.
How high are we talking?
Often in the range of, say, 80 to maybe 95% of the maximum dose, Dmax. So very little buildup compared to photons.
And where does all that surface dose come from? Is it just the main beam hitting the skin?
Not entirely. I mean, the primary electrons from the beam certainly contribute, but a really significant chunk of that surface dose comes from scattered electrons.
Scattered from where?
From all over, really. Electrons that have scattered off components inside the linac head, the scattering foils themselves, the collimators, even the inner walls of that electron cone we just talked about.
Okay.
Plus, there's scatter that happens in the air gap between the end of the cone and the patient's skin, and even some backscatter from the superficial layers of tissue. All this sort of contaminating electron scatter converges right at the surface, bumping that dose up.
Okay, now here's the really interesting part, and it's kind of counterintuitive if you're only thinking about photons. How does this surface dose change with the electron energy?
Right.
With MV photons, higher energy generally means deeper buildup, more skin sparing.
More sparing, yeah.
But for electrons,
It's the complete opposite. The surface dose actually increases as you increase the electron energy.
increases. Why is that?
It's a crucial point, and understanding the why is key. So higher energy electrons, they actually scatter less per unit path length than lower energy electrons, especially when going through low density stuff like air.
Okay.
So think about the beam traveling from the scattering foils down through the air gap inside the cone. Those higher energy electrons, they scatter less sideways before they hit the patient.
Yeah.
This means the lateral spread of those scattered electrons is narrower when they reach the surface. They're more concentrated right there.
Whereas lower energy electrons scatter more widely in the air.
Exactly. They get spread out more laterally over that air gap distance before they even hit the patient, kind of diluting the surface dose contribution over a wider area. So the bottom line, and you absolutely need to burn this into your brain, electron surface dose increases with increasing energy.
Increases with energy. Got it. Opposite of photons. That's definitely a pro for clinics and for exams, for sure.
Huge pearl. Common board question.
Okay, so after that high surface dose, the PDD curve usually shows a little bit of an increase, right?
Yeah.
Up to a maximum dose, the Dmax.
Yes, there is a dose buildup region conceptually similar to photons, but it's generally much less pronounced. The rise isn't as steep.
Right.
And the actual depth of Dmax, well, it doesn't scale quite as predictably with energy as photon buildup depth often does, but we do have typical values for the standard energies we use.
Like what?
Well, for, say, 6 mega electron volts, 6 MeV, a Dmax is often around 1.5 centimeters deep.
Okay.
For 9 MeV, maybe around 2 centimeters. 12 MeV, you're looking at roughly 3 centimeters. 16 MeV, perhaps about 3.5 centimeters.
So Dmax depth does increase with energy, but it's not a simple, like, E divided by some constant rule.
Not as clean as photon buildup, no. But the trend is definitely there. Higher energy, deeper Dmax.
Okay, and then beyond Dmax is where we see that really dramatic effect of the finite range, right?
Exactly. This is the business end of the curve. After reaching Dmax, the dose usually stays relatively high, maybe falls off gradually for a very short distance, and then it just drops off very sharply.
A steep cliff.
A steep cliff, yeah. That rapid dose fall off beyond the region you want to treat. That's what makes electrons so incredibly valuable for sparing those deeper structures. It's a really steep gradient that basically defines how far the beam penetrates.
And that steep fall off leads us to the idea of the practical range, R sub p.
Right. The practical range, R sub p, it's defined as the depth where the dose from the primary electrons has essentially dropped to zero.
Okay.
If you look at a PDD curve, it's usually defined by where that steep falling part of the curve intersects with the low-level Bremsstrahlung tail we'll talk about later. It's basically how deep the vast majority of the primary electrons can get before they just run out of energy.
And there's a super simple, incredibly important rule of thumb for estimating this practical range, isn't there?
There is, and you absolutely positively must know this rule. It's fundamental. The practical range, R sub p, measured in centimeters, is approximately equal to the electron energy in MeV, divided by 2.
R sub p, E2.
R sub p is approximately E divided by 2. Memorize it. It's your quick back-of-the-envelope calculation for figuring out the maximum depth those electrons are going to reach.
So for a, say, 12 MeV beam,
Yep.
the practical range is roughly 12 divided by 2, which is 6 centimeters.
Exactly. At about 6 centimeters deep, those primary 12 MeV electrons have effectively stopped. The dose from them is gone.
R sub p, E2. Simple, essential. Okay, no, that's the practical range where they stop. But the therapeutic range, the depth we actually care about for covering the tumor, is often defined by a higher isodose line, right? Like 80 or 90%.
That's right. We typically prescribe to cover the target with the 80 or 90% isodose line. And yes, we have useful rules of thumb for estimating the depths of those lines too.
Yeah, what are they?
So for the 90% isodose line, which we often call D90, the depth is approximately the electron energy divided by 3.3. E over 3.3.
E3.3 for 90% depth.
Yep. Now, some older textbooks or rules might use E over 4, but E divided by 3.3 is probably the more commonly cited and slightly more accurate value these days.
Okay, E3.3 for D90. What about the 80% line, D80?
The depth of the 80% isodose line, D80, is approximately the electron energy divided by 3. E over 3.
E3.
E divided by 3. Again, older values might sometimes say E over 2.8, but E3 is a really good, easy-to-remember rule. D80 E3.
Okay, hold on. So we've got E3.3 for 90%, E3 for 80%, and E2 for the practical range. That's easy to mix up. How do you keep them straight?
Yeah, it can seem like a jumble at first, but think about it logically in terms of depth. The 90% dose line has to be shallower than the 80% line, right?
Right. Higher dose, shallower depth.
And both of those have to be shallower than the practical range, which is where the dose basically goes to 0 from the primary electrons. So the depths have to increase as the percentage goes down. D90, E3.3 is the shallowest. Then D80, E3 is a bit deeper. And then R sub P, E2 is the deepest.
D90, D80, RP.
Exactly. And the divisors get smaller. 3.3, then 3, then 2. So maybe think. 80% is about 1/3 of the energy deep. E3. 90% is just slightly shallower than that, E3.3. And the practical range is about half the energy deep, P2. Does that help order them?
Yeah, E3.3, E3, E2, shallowest to deepest, divisors 3.3, 3, 2. Okay, that clicks. That structure helps a lot. Thanks.
Good. Those rules are bread and butter for energy selection.
Okay, so we've covered the main part of the PDD curve, high surface, build up to Dmax, steep fall off to RP. But you mentioned a little low-level dose tail beyond RP. Where does that come from if the electrons have stopped?
Yes. That's the Bremsstrahlung tail. It's caused by contaminating X-rays or photons.
Photons in an electron beam.
Yep. As those high-energy electrons are flying through the LINAC head components, the foils, the collimators, the cone, and even as they interact within the patient's tissues, sometimes they pass very close to the nucleus of an atom.
Okay.
And that strong electric field of the nucleus can cause the electron to decelerate very sharply, to change direction abruptly. When that happens, the electron loses energy, and that lost energy is emitted as a photon in X-ray.
That's the Bremsstrahlung process, right? Breaking radiation.
Exactly, Bremsstrahlung. So essentially, a small fraction of the initial electron beam energy gets converted into photons along the way.
And these contaminant photons, they behave like regular photons.
They do. They're generally lower energy and much less intense than the beam you'd get in photon mode, but they are still photons. And photons, as we know, penetrate much deeper than electrons.
Right.
So they create that low-dose tail that extends well beyond the practical range of the electrons, where the electron dose itself has gone to zero.
And does the amount of this photon contamination, this Bremsstrahlung tail, change with the initial electron energy?
Yes, it absolutely does. The probability of Bremsstrahlung production increases with the energy of the electron and also with the atomic number, the Z, of the material the electron is interacting with.
So higher Z materials in the head and higher electron energy.
Lead to more photon contamination. So a higher energy electron beam, say 20 MeV, will have a significantly larger percentage photon tail compared to a lower energy beam like 6 MeV.
How much are we talking about?
Well, for 6 MeV, it might be less than 1% of the maximum dose. But if you go up to, say, 20 or 21 MeV, that tail dose could be up to around 5% of Dmax.
Wow, 5% of the max dose delivered deep inside the patient, potentially hitting critical organs way beyond your target. That could actually be clinically significant sometimes.
It absolutely could be. And it really reinforces the point about selecting the right energy, not just an energy that's high enough. You want the lowest energy that adequately covers your target depth to minimize both the surface dose and this unwanted deep dose tail.
Good point. Energy selection is a balancing act. Okay, so we've got a good handle on how the dose changes with depth. Now let's talk about the beam shape. This is another area where electrons, because of all that scattering, behave really differently from photons.
Very differently. Electron beams definitely do not maintain a nice, neat, rectangular shape as they penetrate tissue.
They get messy.
They get messy, exactly. Because they're light and they're charged, electrons undergo significant multiple Coulomb scattering as they pass through the patient. They're constantly being deflected, jostled around by the electric fields of all the atomic nuclei and electrons they encounter. And all this scattering causes the beam shape, particularly the edges, to change quite dramatically with depth.
And this really impacts the penumbra, right? That fuzzy edge of the beam. How does the electron penumbra change as the beam goes deeper?
It changes significantly. Right at the surface, the sharpness of the penumbra is mostly determined by the scatter that happens before the beam hits the patient in the air gap, off the cone walls. And interestingly, higher energy electrons tend to scatter less in that region, so they often have a slightly sharper penumbra right at the surface compared to lower energy electrons.
It's a sharper edge for higher energy at the skin.
Initially, yes, but that initial sharpness does not last. As the electrons travel deeper into the patient tissue, they undergo more and more lateral scattering. They spread sideways. This causes the penumbra, that transition zone from high dose to low dose at the field edge, to widen out considerably as you go deeper.
So the edge gets blurrier and blurrier with depth.
Exactly. And even though those higher energy beams might start a bit sharper at the surface, their penumbra will actually widen more significantly at deeper depths.
Why more?
Simply because they travel further. They have a longer path length over which to accumulate all that lateral scatter. So more depth means more opportunity to scatter sideways, leading to a wider, fuzzier edge deeper down.
Okay, so the beam edge gets progressively more blurred the deeper you go. That sounds like it has big implications for things like setting field margins or trying to match fields together.
Huge implications. And this scattering doesn't just affect the edges, it affects the shape of the isodose lines within the field too.
How so?
It leads to these very characteristic, sometimes described as heart-shaped or mushroom-shaped isodose contours. Specifically, the high-dose lines, think 80%, 90%, they tend to bow inwards or constrict as you go deeper.
Constrict, so the effective high-dose field size actually gets narrower below the surface.
That's exactly what happens. If you trace out the 90% isodose line, it typically pinches inwards with depth.
Why does it do that?
It's because of lateral scatter equilibrium, or rather, the lack of it near the edges. As you move off the central axis towards the edge, electrons are scattering away from that central region. They're also scattering out of the field edge entirely. This net loss of scattered electrons contributing dose back into the region causes that high-dose area to narrow down.
Okay, so the high-dose lines constrict. What about the low-dose lines, like 20 or 30%?
They do the exact opposite. The low-dose lines, say 20, 30, even 50%, they tend to bulge outwards significantly with depth. It's often called the ballooning effect.
Ballooning. ballooning outwards.
Yeah. Electrons that started well within the geometric field boundary near the surface scatter laterally outwards as they go deeper, carrying the dose into the region just outside the defined field edge at depth.
Huh. So you get this low-dose spray way outside the intended field boundary deep down.
Right.
That sounds like, well, a recipe for trouble if you're trying to put two electron fields right next to each other.
It absolutely is a major planning challenge. That outward bulging of the low isodoses, combined with that widening penumbra we just talked about, is precisely why matching adjacent electron fields, or matching an electron field to a photon field, is so notoriously difficult.
Because those bulging low doses will overlap.
Exactly. If you just simply abut the field edges on the surface, those bulging low dose lines from each field will overlap significantly at depth, creating potential hotspots well outside where you thought the field edge was.
And if you leave a gap to avoid the hotspot,
then you risk creating a cold spot, underdosing the tissue at depth between the fields. It's a tricky balance. So, to really nail this point down, high isodose lines constrict with depth, while low isodose lines BGE outwards with depth.
constrict high, bulge low. Got it. That's a really important visual to keep in mind for planning. Okay, let's move on to actually delivering the dose, thinking about the machine's output and how we collimate the beam. You mentioned earlier that electron output is very sensitive to the collimation setup.
It is, much more so than photon output, generally speaking. And the fundamental reason goes back to scatter. Lateral scatter contributes significantly to the dose measured on the central axis, especially in that buildup region and even around Dmax. So anything in the setup that affects how much lateral scatter reaches the central axis, like the cone size or the cutout size, will directly affect the dose delivered per monitor unit, MU.
And the machine calibration, that's usually done under a very specific standard condition.
Yes. The standard calibration protocols, like TG51 from the AAPM, specify measuring the dose at the depth of Dmax in a water phantom.
Okay.
And it's done using a reference electron cone, typically a fairly large one, like a 10 by 10 or maybe a 15 by 15 centimeter field size, and at a standard source-to-surface distance, SSD, usually 100 centimeters. That measurement gives you the baseline dose rate in centigrade per MU for that reference condition.
But for patient treatments, we're almost always using different cone sizes and definitely using custom cutouts for shaping.
Exactly. For treatments, we use those applicators or cones, which, as we said, attach to the Linac head and often extend down close to the patient. And we ideally want the end of that cone to be pretty close to the skin surface.
Why is keeping that air gap small so important? You mentioned it before.
Right. It's because electrons scatter quite a bit, even in air. If you have a large air gap between the end of the cone and the patient, the electrons have more distance over which to scatter laterally before they even hit the skin.
And that messes things up.
Yeah, it does two main things. It degrades the penumbra, making the field edges fuzzier, less sharp. And importantly, it can also reduce the dose right at the surface because that scattered dose gets spread out more laterally before it arrives. So keep the air gap small, ideally less than about 5 centimeters if possible.
Okay, small air gap.
Okay.
And the final field shaping is done with those custom cutouts, usually Saraband, placed at the end of the cone. How do we figure out how thick that Saraband needs to be to actually block the electrons effectively?
Good question. There's another handy rule of thumb for estimating the minimum thickness needed for adequate shielding. We usually base it on the equivalent thickness of lead first, since lead is denser and a better blocker.
Right.
The required thickness of lead in millimeters is approximately equal to the electron energy in MeV divided by 2. So lead thickness in millimeter, E2.
E2, again, just like practical range in centimeter.
Practical range is E2 in centimeters.
Yeah.
Lead shielding is E2 in millimeters. Easy to mix up, so be careful with the units. Okay. E2 centimeters for range, E2 millimeters for lead thickness. Got it. So for a, say, 9 milli beam, I'd need about 9 divided by 2, which is 4.5 millimeters of lead.
Exactly, 4.5 millimeters of lead. Now, Saraband isn't quite as dense as lead, so it's slightly less effective at stopping electrons per unit thickness.
So you need more of it.
You need to be a bit thicker, yeah. The general rule is that the required Saraband thickness is about 1.2 times the calculated lead thickness.
1.2 times.
Roughly. So for your 9 milliv example needing 4.5 millimeters of lead, you'd need about 1.2 times 4.5 millimeters, which is, 5.4 millimeters of Saraband.
Okay.
And in practice, you typically just round that up to the nearest standard thickness that the mold room uses when they pour the blocks.
Okay, so lead, me 1 millimeters, and Saraband 1.2 times that lead thickness. That's a really practical calculation we need to know.
Definitely.
And you said the size and shape of this cutout also dramatically affects the output, the dose per MU. Absolutely. The output factor, the dose you get for each MU delivered, is highly dependent on both the cone size being used, A and E, the specific size and shape of the cutout placed at the end of it.
So you can't just use the calibration dose rate.
No, you need to apply correction factors.
Sure.
We use measured factors, often called relative cone output factors or just output factors, that compare the output for your specific cutout combination to the output under the reference calibration conditions. These factors have to be measured for each machine and energy.
And there's a particularly important effect that happens if that cutout gets really small, right?
Yes, the small cutout effect. This is a really key concept. It occurs when the physical size of your cutout projected onto the patient's surface becomes smaller than the lateral distance electrons need to travel to establish scatter equilibrium.
Smaller than the scatter range.
Essentially, yeah. If the field is too narrow, electrons that would normally scatter sideways into the central part of the beam from the periphery are instead scattering out of the small field altogether. You're losing that essential side scatter contribution.
Okay. And what are the main consequences of this small cutout effect? What happens to the beam?
Two major things happen that you absolutely must remember for planning and definitely for your boards. First, the dose in centigrade per monitor unit will decrease. You get less dose bang for your MU buck compared to a larger field.
Output drops. What's the second thing?
Second, the depth of maximum dose, Dmax, will shift shallower. It moves closer to the surface.
Okay, output drops. Dmax gets shallower.
Yeah.
Why? Why does losing that side scatter do that?
Well, the output drops simply because you have less total scatter contributing to the dose on the central axis. Fewer scattered electrons arriving means lower overall dose.
Makes sense.
And Dmax gets shallower because that lateral scatter is also crucial for the dose buildup process. You need electrons scattering in from the sides to build the dose up from the surface to its maximum value. If you lose that scatter contribution in a small field, the peak dose just occurs earlier, closer to the surface.
Okay. So bottom line, if your cutout size is smaller than the electron range, either the practical range RP or just the lateral scatter range, then the output drops and Dmax gets shallower.
That's the rule. Critical point. Burn it in.
Output drops, Dmax shallower for small cutouts. That's definitely crucial, especially if you're treating like a tiny scar boost or a little eyelid lesion or something. You can't just assume the standard PDD and output factor apply.
Absolutely not. You need specific data or calculations for those small fields.
Okay. Let's broaden out a bit now and talk about some other planning considerations that make electron planning, well, uniquely challenging sometimes.
For sure. There are several factors you need to pay close attention to with electrons that are either less critical or handled quite differently when you're planning with photons.
One that comes to mind is the inverse square law. With photons, we typically think about the source being at the physical target, maybe 100 centimeters away. But for electrons, it's not quite that simple, is it?
No, it's not. Because of all that scattering that happens inside the Linux head, remember the scattering foils, the collimators, the cone walls?
Yeah.
The electrons don't appear to be radiating nicely from a single point source way back where the photon target would be, which isn't even in the beam for electrons. Instead, they appear to originate from a theoretical point called the virtual source.
Virtual source, where is that?
It's effectively somewhere closer to the patient, often located conceptually between the scattering foils and the patient's surface. The distance from this virtual source to the patient's surface is what we call the effective source-to-surface distance, or SSD effective.
And that's not necessarily 100 centimeters.
No, it's typically less than the physical 100-centimeter SSD we think about for photons. It varies depending on the electron energy and the specific machine design, but it's usually somewhere in the range of, say, 80 to 95 centimeters.
Okay. And this SSD effective, that's the distance we must use when we're applying the inverse square law correction, right?
Mm-hmm.
Especially if we're treating at a non-standard distance, like with an extended air gap.
Absolutely critical. If you are treating at an SSD that's different from the distance used during the machine calibration, which itself is referenced to the virtual source, even if nominally 100 centimeters, you absolutely need to apply an inverse square factor correction to your monitor unit calculation.
You know, there's a specific formula for that electron inverse square factor.
There is. The formula for the inverse square factor for electrons, let's call it ISF electron, is designed to correct the output specifically for a change in the air gap between the standard setup, usually end of cone at calibration SSD, and the actual treatment setup. It's calculated as, okay, get ready, it's the quantity SSD effective plus Dmax all squared.
Okay, SSDF plus Dmax 2.
Divided by the quantity SSD effective plus the actual air gap plus Dmax all squared.
Okay, let me repeat that back. ISF electron, SSDF plus Dmax 2. SSF plus air gap plus Dmax too.
That's the one.
And why is Dmax in there?
Because the output calibration measurement is typically performed at the depth of Dmax, so we're referencing the distances back to that point of measurement. The air gap in the denominator is the extra distance between where the cone was for calibration, nominally at SSF from the virtual source, and where the patient's surface actually is during treatment.
Right, so if my SSD effective is, say, 90 centimeters, and my Dmax for this energy is 2 centimeters, and for this patient I have an extra 3 centimeter air gap between the cone and skin.
Okay.
My ISF would be 90 plus 2, 2 divided by 90 plus 3 plus 2, 2. So 92 squared divided by 95 squared.
Exactly. Which will be a number less than 1, meaning your output at that increased distance is lower, as you'd expect from inverse square.
Got it. So you absolutely need to know your machine's SST effective values and use this formula for extended distance treatments.
Crucial for accurate dosimetry. Okay, what about treating surfaces that aren't nice and flat, perpendicular to the beam, oblique surfaces?
Oh yeah, obliquity. That seems like it would be a real headache with electrons, given how much they scatter.
It absolutely is a headache. When the electron beam hits the patient's surface at an angle, the dose distribution gets significantly messed up compared to perpendicular incidence.
How so?
Well, for one thing, the depth of maximum dose, Dmax, tends to shift shallower. It moves closer to the surface along that angled beam path.
Okay, Dmax gets shallower.
Also, the dose fall off beyond Dmax usually becomes less sharp, more gradual. The nice steep cliff gets smoothed out a bit.
Less therapeutic advantage then.
Potentially, yes. And perhaps most importantly, you can get significant dose perturbations, hot spots, and cold spots developing, particularly under the edges of the field where the beam is entering at the most oblique angle. It can get quite complex.
Yikes. Okay. And another big one. Inhomogeneities inside the patient. Things like bone or lung in the beam path. We know photons are affected, but electrons are way more sensitive, right?
Orders of magnitude more sensitive, yes. It's a huge factor in electron planning. Because electrons lose their energy primarily through collisions and scattering interactions with atomic electrons, passing through materials with different electron densities has a drastic effect on both their range and their scattering behavior.
Whereas photons interact differently. Compton, photoelectric, more dependent on mass density and Z.
Generally, yes. Photons are less severely perturbed by density variations compared to electrons. Electrons really feel those density changes.
So if you have, say, a low-density lung cavity or a high-density rib bone sitting right in the middle of your electron field,
it can really wreak havoc on the dose distribution downstream.
how do we even try to account for that in planning?
Well, the planning systems use sophisticated algorithms, but conceptually, we sometimes use a factor called the coefficient of equivalent thickness, or CET. Yeah, coefficient of equivalent thickness. The CET for a given material basically relates its physical thickness to an equivalent thickness of water in terms of how much it affects the electron range. It's approximately equal to the electron density of the material divided by the electron density of water.
Okay, electron density ratio. So for bone, which has a higher electron density than water,
its CET would be greater than 1. Maybe around 1.6 or 1.7, depending on the bone density. This means that, say, 1 centimeter of bone is equivalent to maybe 1.7 centimeters of water in terms of stopping the electrons. It effectively shortens the electron range if the beam has to pass through bone.
Okay. And for lung is mostly air, very low density.
Right. For lung tissue, the electron density is much lower than water, so its CET is much less than 1, maybe around 0.2 or 0.3.
So a centimeter of lung only counts as like 0.3 centimeters of water for stopping power.
Exactly. Which means the electron range is effectively lengthened if the beam passes through lung. The electrons will travel much deeper in lung than they would in the same thickness of water or soft tissue.
So if you're treating a chest wall and there's lung right underneath, the electrons could shoot way deeper than you planned based on just the physical depth.
Precisely. And if there's a rib in the way, they'll be stopped much shallower just behind the rib.
Creating shadows and hotspots.
Exactly. And it's not just the range effect. The scattering at the interfaces between different density tissues is incredibly complex. For example, when electrons go from soft tissue into low-density lung, you often see a decrease in dose right inside the lung, just beyond the interface.
A decrease, why?
It's called loss of side scatter equilibrium. Electrons that were scattering laterally into that region from the denser tissue next door are suddenly gone when you enter the low-density lung. So you get a local cold spot right near the interface before the dose might build up again further in.
Wow. Okay, so this really highlights why accurate heterogeneity corrections in the treatment planning system are just absolutely non-negotiable for electron planning.
Crucial. Simple water equivalent path length adjustments often just don't cut it. You need algorithms that model the scatter properly.
Okay, so this extreme sensitivity to inhomogeneities, plus those unique isodose shapes we talked about, the constricting high doses, the bulging low doses, it all seems to make field matching a real nightmare.
It's definitely one of the trickiest parts of clinical electron therapy. Matching an electron field to another electron field, or maybe more commonly, matching an electron field to an adjacent photon field requires very, very careful planning to avoid significant hotspots or cold spots right at the junction.
Let's take that common example, treating a breast case. You might use tangential photon fields for the breast or chest wall, and then maybe an anterior electron field for the supraclavicular nodes. Where does that classic junction hotspot typically show up?
Yes, the supraclavicular junction. That common hotspot usually occurs just on the photon field side of the junction line.
On the photon side, not the electron side.
Typically on the photon side, yeah. And it's usually most pronounced at relatively shallow depths just below the skin surface.
Why there? Why on the photon side?
It's primarily due to that lateral scatter of electrons we keep talking about. Lower energy scattered electrons from the edge of the electron field spill sideways, across the junction line, and into the adjacent edge of the photon field.
Okay.
Now, the photon field edge, especially near the surface, doesn't have as much inherent incoming lateral scatter compared to the electron field. So when these extra scattered electrons from the electron beam dump their dose into that relatively underscattered region of the photon field, it causes a relative dose enhancement and overdose, a hot spot right there along the photon side of the match line.
Ah, okay. So the electrons are basically polluting the edge of the photon field with extra scatter dose. That makes sense.
Clever.
Okay, one last specific planning issue that's really unique and potentially nasty with electrons. Backscatter.
Yes, electron backscatter. Super important concept, especially when you're treating anywhere near metal, like in head and neck cases or sometimes chest walls with implants.
What is it?
It happens when you have high atomic number, high Z materials. Think metal dental fillings, gold crowns, titanium reconstruction plates, maybe even pacemaker wires located distal to your target volume.
Distal meaning deeper than the tissue you're actually trying to treat.
Exactly, deeper in. When the primary electron beam passes through your target tissue and then hits this high Z material deeper down, a significant fraction of those electrons can get scattered backwards, back towards the direction they came from, towards the surface.
They literally bounce back.
Effectively, yes. High Z materials are very efficient at causing large angle scattering. Think Rutherford scattering off the nucleus. So they act like electron mirrors to some extent.
Okay.
And these backscattered electrons travel back into the tissue that's lying immediately proximal to the metal, the tissue superficial to the metal.
And that causes...
That causes a localized dose enhancement, a hot spot, right in that superficial tissue layer just in front of the deep metal.
How big of a dose increase are we talking about? Is it minor?
Oh, no, it can be quite significant. It can potentially increase the dose to that tissue immediately superficial to the metal by, say, 10 to 30%, sometimes even more.
10 to 30% extra dose. Wow.
Yeah. And it's particularly problematic for lower energy electron beams because they tend to undergo larger angle scattering more readily.
So, classic example. Treating a cancer on the lip or the inside of the cheek with maybe 6 MeV electrons, and the patient has big metal fillings or crowns right behind that tissue.
Exactly. In that scenario, the inner surface of the lip or the buccal mucosa right next to that metal filling could get a substantial overdose due to backscatter.
Which could lead to nasty side effects, right?
Yeah.
Like severe mucositis or even tissue breakdown.
Absolutely. It can cause significant complications if it's not anticipated and managed.
So how do we manage it? What's the clinical solution?
The standard approach to mitigate this backscatter effect is to place some bolus material, often just a piece of dental wax or similar tissue equivalent material, directly over that tissue metal interface. So you put the wax between the superficial tissue surface you're treating and the underlying metal structure.
Okay, sandwich some wax in there. How does that help?
The bolus basically acts as an absorber for those backwards traveling electrons. The electrons scatter back from the metal, but then they run into the wax bolus before they can reach the sensitive superficial tissue.
Ah, they get stopped in the wax.
Exactly. The bolus material, being tissue equivalent, absorbs those backscattered electrons, preventing them from delivering that extra dose to the patient's actual tissue. You sacrifice a bit of dose uniformity right at the interface, maybe within the wax itself, but you protect the healthy tissue from that potentially damaging hotspot.
That's a really elegant and practical clinical trick. Super important pearl to remember. Okay, let's try and bring all these physics details together now. Given all these unique characteristics, the finite range, the scatter, the surface dose, the backscatter, what are the main clinical reasons we actually choose to use electrons instead of photons?
Well, the single biggest overriding reason we choose electrons is for treating shallow targets. That's their niche.
Because of that finite range.
Because of that finite practical range, R sub p approximately E/2. That is the absolute key feature.
So anywhere the disease is confined to the first few centimeters below the skin. Like skin cancers, obviously.
Skin cancers are a classic example, yeah. Basal cells, squamous cells.
Or maybe superficial lymph nodes, like in the axilla or groin.
Yep. Nodal basins that are close to the surface. Post-mastectomy chest walls are another huge application, treating the scar and chest wall while sparing the lung and heart underneath.
Makes sense. Scar boosts, maybe treating ribs if they're involved superficially. Lip lesions.
Exactly. Any situation where the target depth is limited, electrons are potentially ideal because they let us deliver that high tumoricidal dose to the shallow target while ensuring the dose just plummets dramatically right beyond it. That spares the deeper critical organs, lung, heart, spinal cord, bowel, whatever lies beneath.
And what's the typical depth limit? How deep can we realistically treat with electrons?
It depends a bit on the maximum energy your LINAC can produce, but generally, the practical upper limit for clinical electron beam therapy is somewhere around 8 to maybe 10 centimeters deep at the very most. Beyond that, you usually need photons.
Okay. And within that range, selecting the right energy is absolutely paramount, isn't it? To make sure you cover the target adequately but don't overshoot.
It is probably the single most important decision you make in electron planning. You absolutely must choose an electron energy that's high enough so that your chosen therapeutic isodose line, usually the 80 or the 90% line, covers the full depth of your planning target volume, your PTV.
And we use those rules of thumb we talked about, but kind of in reverse, right?
Yeah.
To pick the energy based on the depth needed.
Exactly. You work backwards. Let's say your target, your PTV, extends down to a depth of maybe 3.5 centimeters.
Okay, 3.5 centimeters deep.
And let's say your department policy is to cover the PTV with the 90% isodose line.
Cover 3.5 centimeters with D90.
Right. So you pull out your rule of thumb. D90 is approximately E divided by 3.3.
D90, E 3.3.
Now you need to find E, so you rearrange the formula. Energy is approximately 3.3 times D90.
E 3.3, D90.
So in your case, E 3.3 times 3.5 centimeters, which is, let's see, 11.55.
Okay, 11.55 MeV. But LINACs don't usually have 11.55 MeV, right? They have discrete energies like 9, 12, 16.
Correct. So 11.55 MeV is the minimum energy you theoretically need. 9 maybe would be too low. Its D90 would be around 93.3, 2.7 centimeters, not reaching 3.5 centimeters. So you'd have to go up to the next available standard energy, which is likely 12 MeV.
Use 12 MeV.
Yeah. 12 MeV should give you a D90 around 123.3 or 3.6 centimeters, which would comfortably cover your 3.5 centimeter target depth. You might even consider 16 MeV if the target was slightly deeper, or if the 12 MeV beam from your specific machine was known to be a bit underpowered. But generally, you pick the lowest standard energy that reliably achieves the required coverage.
And you want the lowest energy that works because?
Because, as we discussed, going to excessively high energies, even if they cover the target, comes with downsides. Higher energy means higher surface dose.
Right, increases with energy.
And it also means a larger photon contamination tail, delivering unwanted dose to deeper tissues beyond the target. So it's always a balance. Enough energy for coverage, but not more than necessary.
Makes perfect sense.
Yeah.
Lowest energy that covers the depth. Okay, and one last clinical point. Setup sensitivity. Electrons seem like they'd be really unforgiving if the setup isn't perfect.
They are incredibly sensitive to setup variations. Huge factor. Because of that high surface dose, the very sharp dose fall off, and that extreme sensitivity to scatter and inhomogeneities, getting the patient positioned correctly and consistently is absolutely vital.
So things like bolus placement. If you need bolus, say, to bring Dmax right up to the surface for a very superficial target like a keloid scar, or maybe just to flatten out an irregular surface.
That bolus placement has to be meticulous. It needs to be directly on the skin with no air gaps underneath.
Because air gaps are bad.
Air gaps are the enemy. As we said, air gaps, whether they're under the bolus or between the end of the electron cone and the patient's skin, they significantly degrade the dose distribution. They blur the penumbra, and critically, they can reduce the surface dose, potentially causing you to underdose the most superficial part of your target.
Yikes. So good contact is key.
Good contact, minimal air gaps, and accurate patient positioning and good immobilization are also vital. If the patient shifts even slightly, you could easily move the edge of the field relative to an underlying inhomogeneity like bone or mess up a field junction, leading to potentially significant hot or cold spots. Electrons demand precision in setup.
Okay, that's a lot of detail. Let's try and distill this all down now into absolute must-remember highlights, the kind of things you'd call clinical pearls for electrons, stuff that's crucial for board exams, but also just for safe, effective daily practice.
Right, let's consolidate the absolute core knowledge, the must-knows.
Okay, pearl number 1.
Point number 1 has to be the depth dose characteristics. Remember, high surface dose, and critically, that surface dose increases with increasing energy. Remember the broad Dmax. Remember the steep dose fall-off leading to that finite practical range, R sub P, which is approximately energy divided by 2 in centimeters. And absolutely know those therapeutic range rules. D90 depth is approximately energy divided by 3.3, and D80 depth is approximately energy divided by 3. You have to know those rules cold.
Okay, depth dose, high surface, isodose shape, broad Dmax, steep fall-off, RP 2 centimeters, D90 3.3, D80 3. Got it. Pearl number 2.
Number 2, isodose shape. Remember the visual. High isodose lines, 80-90% constrict or pinch inwards with depth due to loss of lateral scatter. Low isodose lines, 20-30-50%. Below G outwards balloon due to lateral scatter carrying dose outside the geometric edge. And related to that, the penumbra widens significantly with depth.
Isodose shape, high constrict, low bulge, penumbra widens. Okay, pearl 3.
Number 3, output factors and collimation. Electron output, dose per MU, is very sensitive to the cone and cutout size. Crucially, remember the small cutout effect. If the cutout size is smaller than the range needed for lateral scatter equilibrium, the output will decrease and the Dmax depth will shift shallower. And for calculations involving distance, always use the effective SSD, SS defective, for your inverse square law corrections.
Output, sensitive to cutout, small cutout output, Dmax shallower. Use SS def for ISL. Got it. Number 4.
Point number 4, photon contamination. Remember, this is the Bremsstrahlung tail. It increases with increasing electron energy, and it causes that low-dose tail extending beyond the practical range RP, potentially delivering unwanted dose to deeper structures.
Photon contamination. Bremsstrahlung tail, AWE, dose beyond RP. Okay, pearl 5.
Number 5, electron backscatter. This is that dose increase that occurs proximal superficial to a high atomic number Z material that's located distal deeper to your target. It's caused by electrons scattering backwards off the metal. Remember, this can be a significant hotspot, 10-30% increase, and you can often mitigate it by placing bolus over the tissue-metal interface.
Backscatter, dose proximal to distal high Z, mitigate with bolus.
Right.
And the last one, number 6.
And finally, point number 6. Clinical use. Why do we use them? Electrons are primarily for shallow targets, typically less than 8 to 10 centimeters deep. Their finite range is their superpower, allowing us to effectively spare deeper critical tissues.
Clinical use. Shallow targets, 8 to 10 centimeters, spares deep tissues. Perfect.
Those 6 points, along with the rules of thumb and understanding the basic why behind those effects, that really forms the core foundation of electron physics knowledge you need for safe practice and for exams.
Excellent summary. All right, you ready to put this knowledge straight to the test? Let's do a quick board blitz. I'll give you some scenarios. You walk us through the thinking.
Okay, let's do it. Lay 'em on me.
Question 1. A patient needs treatment to a target depth of 3 centimeters. Your clinical goal is to ensure the 90% isodose line covers this depth adequately. Using the rule of thumb D90 E3.3, which of the following standard electron energies would likely be the most appropriate choice? Your options are A6 MeV, B 9 MeV, C12 MeV, or D16 MeV.
Okay. Target depth is 3 centimeters, needs to be covered by the 90% line, so D90 equals 3 centimeters. The rule is D90E divided by 3.3. We need to find the energy E, so rearrange. E 3.3 multiplied by D90. That's E a C free 3.3 times 3 centimeters, which equals 9.9 MeV.
9.9 MeV needed.
Right. Now look at the options. 6 MeV is way too low. 9 MeV is very close, but 9.9 is slightly more than 9, so 9 MeV might be borderline or slightly insufficient. Its D90 would be about 93.3 at 2.7 centimeters. 12 MeV is the next standard energy up. Its D90 would be roughly 12 divided by 3.3, which is about 3.6 centimeters. That would definitely cover the 3-centimeter depth. 16 MeV would also cover it, but it's higher than necessary. So the best choice to ensure adequate coverage without using excessive energy is C, 12 MeV.
Excellent reasoning. Spot on. Okay, question 2. You're planning a treatment that involves a budding field specifically, tangential photon fields for the breast or chest wall, matched to an electron field for the supraclavicular nodes. Where is the region of highest dose, the hotspot typically located at the junction between these two fields? Is it A, deep within the electron field, B, deep within the photon field, C, just inside the geometric edge of the electron field at depth, or D, just inside the geometric edge of the photon field at depth?
Okay, the electron-photon junction hotspot, we talked about this. It's caused by the lateral scatter of electrons from the electron field spilling over into the edge of the photon field. That scatter adds extra dose to the photon side, which doesn't have as much incoming scatter of its own right at the edge, especially near the surface. So the hotspot is typically located D, just inside the geometric edge of the photon field at depth.
Perfect. Exactly right. Question 3. You are planning to treat a small 3-centimeter diameter skin lesion using a 16 MeV electron beam. To shape the field, you use a custom 3 centimeters by 3 centimeter square cutout placed at the end of the electron cone. Compared to the central axis depth dose curve you'd get for a standard large 10 by 10 centimeter cone using the same 16 MeV energy, what is the most likely consequence of using this small 3 by 3 cutout on the central axis depth dose? Will A, Dmax shift deeper and the output increase? B, Dmax shift shallower and the output decrease? C, Dmax remain the same but the output decrease? Or D, Dmax shift shallower but the output remain the same?
Okay, let's break this down. We've got a 16 MeV electron beam. First, what's its range? Practical range RPAE2 centimeters, so 162 equals 8 centimeters. The cutout is 3 centimeters by 3 centimeters. That's significantly smaller than the 8 centimeter practical range, and it's likely smaller than the lateral distance needed for full scatter equilibrium. So this is definitely the small cutout effect scenario.
Yeah, small cutout effect.
And what does the small cutout effect do? It means you lose lateral scatter contribution coming into the central axis. Losing that scatter has two main consequences. First, less total dose on the central axis, meaning the output, centigrade per mu, decreases. Second, less scatter contributing to the buildup process, meaning Dmax shifts shallower, closer to the surface. So we're looking for shallower Dmax and decreased output. That matches option B.
Nailed it again. Option B is correct. Output drops. Dmax shallower. Okay, final board blitz question. You're treating a lesion on the patient's jaw, right over an area where there's a known titanium dental implant located deeper in the bone. You're using a 6 MeV electron beam. There's a risk of causing an unwanted dose increase, a hotspot, in the soft tissue that lies immediately superficial to that implant. This dose increase is primarily caused by which of the following? A, increased photon contamination generated by the implant material. B, focusing of the electron beam by the curved shape of the implant. C, backscatter of low-energy electrons from the high atomic number implant material. Or D, reduced attenuation of the primary electron beam by the implant, allowing more dose to reach the superficial tissues.
Okay, treating over metal with electrons. This screams backscatter. Titanium is a relatively high Z material compared to tissue. When the 6 MeV electrons penetrate the superficial tissue and hit the deeper titanium implant, the high Z of the titanium causes a significant number of electrons to scatter backwards towards the surface. These backscattered electrons then deposit extra dose in the tissue layer lying just proximal or superficial to the implant.
Right.
It's not A, photon contamination causes a deep tail, not a proximal hotspot. It's not B, implants don't typically focus electron beams. And it's not D, the implant would increase attenuation of the forward beam, not reduce it. So the primary cause is definitely C, backscatter of low energy electrons from the high Z implant material.
Fantastic. Walk through all of those perfectly. Hopefully, tackling those problems really helps solidify how these sometimes abstract physics principles translate directly into real-world clinical decisions and, yes, board exam questions.
Yeah, seeing the application definitely helps cement the concepts.
And don't worry if you feel like you need to review these rules constantly. We've all been there trying to frantically remember the Sarabande thickness calculation or explain the small cutout effect, the day after passing the physics boards.
Oh, that is absolutely true. It definitely takes a little while for it all to sink in and become second nature, but eventually you realize, hey, I actually did learn this stuff.
Right. You find yourself sketching PDD curves on napkins during lunch breaks.
It happens once physics gets its hooks into you.
It's there to stay. Okay, let's just quickly circle back one last time and summarize the absolute key takeaways from our whole discussion on electron beams, just to really hammer home the most critical points.
Sounds good. So quick recap. Electrons are our tool for shallow targets, usually less than 8, maybe 10 centimeters deep. Their superpower is their finite range, RP2E2 centimeters, which lets us spare deeper tissue.
Their depth dose is unique. High surface dose, and remember it increases with energy. A broad Dmax, then a steep fall off. Know the therapeutic range rules. D90, E3.3, D80,
Isodose shapes change with depth. High doses constrict inwards, low doses bulgy outwards, ballooning, and the penumbra gets wider. This makes matching tricky.
Output depends heavily on collimation. Remember the small cutout effect. Output decreases, and Dmax shifts shallower if the cutout is smaller than the range. And always use the effective SSD for inverse square corrections.
Don't forget the photon contamination. That brim-Strahling tail gets bigger with higher energy and adds dose beyond the electron range. And finally, watch out for electron backscatter off distal high Z materials. It causes a hotspot proximal to the metal, but you can often mitigate it with bolus.
Fantastic. Those are the core principles. Mastering these is really essential, not just for exams, but for using electrons safely and effectively every day for our patients.
Absolutely. Applying this physics correctly is what lets us truly harness the power and precision of electron beams for treating superficial disease.
Complete practice oral boards at RadOncSmartLearn.com and subscribe to RadOnc Smart Review for our next exploration into the fascinating world of radiation physics. Thanks for tuning in.